As a valued NEI podcast listener, get $100 off NEI Fall Congress registration with code POD26. That's POD26. Go to nei.global/fall, FALL, to sign up today. Early bird rates end on June 30th. Register early before it sells out.
Welcome to the NEI podcast, PsychopharmaPearls, a brand new series created for busy clinicians. Hosted by Dr. Andrew Cutler, psychiatrist, psychopharmacologist, and chief medical officer of NEI. These 30-minute episodes deliver practical psychopharmacology pearls and real-world strategies you can put into practice right away to better support your patients.
Hello and welcome to another NEI podcast, and this one is in our series of PsychopharmaPearls, and we'll be talking about Akathisia versus Agitation with Dr. Leslie Citrome. Dr. Citrome, how are you?
I'm great. Thank you, Dr. Cutler, for having me here today.
Well, it's a pleasure. Well, let's just get started, shall we? Why is it so important for prescribers to distinguish akathisia from agitation? Aren't they similar?
Well, they can look alike, but let's go over the definitions first.
Okay.
Akathisia is a movement disorder. It's drug-induced. It's generally acute. We think of akathisia as part of the whole constellation of drug-induced movement disorders, such as drug-induced Parkinsonism, dystonia, akathisia. They all can appear when you start an antipsychotic or when you increase the dose. Now, drug-induced Parkinsonism is pretty obvious when you see it, so is dystonia. Akathisia can be more subtle.
Mm-hmm.
So akathisia, by definition, is the feeling of inner restlessness, and sometimes you can observe patients pacing about, not sitting in one comfortably, and being rather feeling like they have ants in their pants if you ask them.
Mm-hmm.
And that's quite different. And sometimes we mistake that for anxiety and possibly agitation, because agitation is an increase in physical and verbal activity that is out of the ordinary for that individual person. And we worry about, of course, that agitation can escalate to aggression.
Mm-hmm.
So there are different things. They can look very similar. Someone who has akathisia is uncomfortable and looks like they're squirming, and someone who's agitated can look exactly that way.
Mm-hmm.
But let's take a look at what we do when we see someone who's agitated. Sometimes if they have akathisia and we think it's agitation, well, we can increase the dose of the antipsychotic.
Mm-hmm.
That will make akathisia worse.
Mm-hmm.
It's not going to treat the agitation. So that's the major obstacle here and the importance of why we must distinguish the two.
Right. Right. So if you confuse psychotic agitation when it's really akathisia, you're likely to increase the dose to treat that, but you're going to make it worse. Okay, I think I got it. That's the clinical relevance here.
Absolutely. Let me give you an example. So for those of our listeners who work in emergency departments, and some of you probably still use haloperidol, although I would not, but let's say you are, and someone is agitated, and you give them an injection of haloperidol intramuscularly, and they seem to get worse. And then you give another shot, and they get even worse. What you're probably seeing is akathisia, which is dose-related and is a drug-induced movement disorder.
Is there a difference in the subjective experience? I mean, akathisia I think of as a sense of restlessness, uncomfort, got to move. Is that different from agitation?
Well, if you're lucky enough for the patient to be articulate and tell you how they feel inside, they might express a feeling of inner restlessness. Someone who's agitated may also complain of feeling restless and irritable.
I see. Okay. So now I've got a patient and they're getting restless or irritable after I start or increase the antipsychotic. Are there any clinical features, timing of the symptoms, or anything that can help us distinguish the two?
I think the biggest tell is the akathisia becomes worse when you medicate it with an antipsychotic. So generally, someone who's agitated will become more calm with an antipsychotic. And that's probably going to be the way that one discovers that someone has akathisia. It used to be a much bigger problem with first-generation antipsychotics, but we sometimes see it with second-generation antipsychotics, especially the dopamine receptor partial agonists.
Partial agonists, that's true. But short of increasing the dose and risking making someone worse, are there any other clues before I do that would help me distinguish them?
It's difficult. There could be a reason why someone is agitated. Something could have happened to them. They may have been brought into the emergency department, for example, against their will, or they had an encounter with someone on the inpatient unit and they're agitated because of that. Someone with akathisia may be just sitting quietly, minding their own business.
I see.
And they feel restless. So that's one way of distinguishing the two.
I see.
But you have to actually know what they were doing before,
right,
and the entire environmental context of how they're feeling.
Yeah, that's really helpful. So the precipitant also might be something that could help us. And then what about somebody's experiencing significant psychotic symptoms? Does that make it more likely to be agitation? Could that be driving it?
Well, I would think so. If they have florid hallucinations and delusions and rather extreme positive symptoms of schizophrenia, that's very distressing. And they can be agitated under those circumstances. And you will want to treat it, let's say, with an antipsychotic. And if they seem to get worse, though, then you're barking up the wrong tree, as I say, and they probably were seeing akathisia due to what they received beforehand.
Okay, so that certainly helps and makes a lot of sense. If you do suspect that it's akathisia, what are the best ways to handle that?
Well, akathisia cannot be treated with benztropine or any other anticholinergic agent.
Hang on a second. So I always thought of acute drug-induced movement disorders like Parkinson's. You would use an anticholinergic, benztropine.
Well, that would be the case
work here
for drug-induced Parkinsonism and acute dystonia.
Okay.
It is not the case for akathisia.
Okay.
Akathisia is not ameliorated by anticholinergic treatment.
Okay.
And in fact, using an anticholinergic won't do anything for the akathisia. Okay. What we need to do, there's actually three strategies that we can employ. We can lower the dose of the antipsychotic. We can change the antipsychotic. If we can't do either one, we can add a beta blocker or mirtazapine. Mirtazapine actually works better than a beta blocker, but it's not as well tolerated.
Okay.
Someone taking mirtazapine may become more sedated and have a greater degree of their appetite may be increased, and that could be a problem for some patients.
Sure.
But if well tolerated, mirtazapine in meta-analyses was demonstrated to be superior to a beta blocker.
Now that's fascinating because as someone who's done clinical trials, I know you have as well, we always use a beta blocker such as propranolol to treat that. And mirtazapine is not usually one of the things that they suggest that we use, but it is very evidence-based.
Right. The classic antidote for akathisia has been a beta blocker. We've been using that for decades. The mirtazapine is a relatively recent innovation in terms of antidepressant therapy, and it's also its use in addressing akathisia.
Right. What would well, let me back up. So obviously the pathology is a little different here. When we're talking about dystonia or Parkinsonism, we're talking about an imbalance of dopamine and acetylcholine. The fact that a beta blocker works, which is a norepinephrine receptor, suggests it's dopamine and norepinephrine, but what's the mechanism of mirtazapine?
Well, probably similar. But we don't really know. We haven't elucidated the pathophysiology of akathisia all that well. We understand drug-induced Parkinsonism. That's easy. You block a dopaminergic transmission in the motor striatum, and boom, you have Parkinsonism and perhaps even acute dystonic reactions. We don't quite understand akathisia. And the other puzzle, to me anyway, is its presence in when we use dopamine receptor partial agonists. What makes them really all that different? So there's a kind of a mystery behind akathisia, and for all practical purposes, we treat it empirically with what we've known has worked in the clinic.
Well, it's possible mirtazapine does have some anti-alpha receptor properties. So I'm just reasoning here, maybe a little norepinephrine, and then there's some 5-HT2A antagonism, which could potentially be helpful here. So I realize I'm just speculating, Les.
Yeah, I mean, you can identify other interventions that have a similar pharmacology, and yet we don't really use it for akathisia. So it's a bit of a mystery to me.
Right.
But once someone starts to use an intervention for, let's say, akathisia and writes about it, other people want to replicate this. And before you know it, you have a treatment that's generally well accepted, that is evidence-based. It's not to say that other things don't work. They just didn't get studied.
How about gabapentin? I've heard that may be helpful.
I've had no experience using gabapentin specifically for akathisia. I probably wouldn't go there. But, there's something that we didn't talk about yet that is real important. We cannot let akathisia go on. Akathisia can ultimately lead to partial or non-adherence. It could also, if its patient continues to take their medicine and continue to be akathisia, it's been associated with self-harm and harm to others.
Oh, my.
And that's very clear.
Yes. I believe there's also an association with suicide, sadly, and certainly anxiety and depression. It makes you uncomfortable.
So harm to self is above and beyond what would have been present with a mood disorder. So it exacerbates these feelings. And it's a feeling of lack of control and being very uncomfortable. Someone with akathisia is not comfortable.
Well, I think this is an important distinction you're making, because the definition of akathisia actually requires a subjective component. It's not merely motor activity or looking restless. They have to endorse feeling restless and it being distressing, right?
Yeah, absolutely. So the Barnes Akathisia Rating Scale is used in research to measure the severity of the akathisia. And in order for akathisia to be noted on that scale, you must have a restless feeling that's subjective. If you don't have that, you don't have akathisia. Some people call it pseudo-akathisia.
Yes, I've heard that.
Sometimes it's very difficult for the patient to articulate how they're feeling inside. So I would likely treat pseudo-akathisia just like akathisia.
Yes.
But in a research setting, that inner sense of restlessness must be present.
Yeah, I was always a little uncomfortable with the term pseudo-akathisia because it still has the word akathisia in it, I guess. It's confusing. What about benzodiazepines?
Benzodiazepines can help, but it's a stopgap measure. I don't think you would want to continue using a benzodiazepine long term. Number one, it may stop working. Number two, if a person decides to decrease their dose or stop it entirely on their own, they might experience some symptoms of withdrawal.
I see. So you had mentioned lowering the dose. So it sounds like akathisia, it can be dose and blood level related here?
Yeah, so akathisia is dose related, and we can look at some of the dopamine receptor partial agonists and look at the studies that were done with fixed doses, and you can clearly see that the adverse event rate of akathisia was substantially higher at the higher doses.
Yes.
In fact, I usually teach residents that if they see akathisia and the dose that they're giving is not unusually large, look for a drug-drug interaction that they may have possibly missed.
Well, this is very important because you mentioned D2 partial agonists. Some of them are metabolized by cytochrome P450 enzymes that are vulnerable to inhibition and raising the blood level. That's an excellent clinical pearl.
Yeah. So let's give some examples here. The ABCs, aripiprazole, brexpiprazole, and cariprazine. Aripiprazole and brexpiprazole are metabolized by CYP2D6 and CYP3A4, and cariprazine by CYP3A4.
Yeah.
So the presence of inhibitors of these enzymes will increase the plasma level of that respective dopamine receptor partial agonist and increase the risk of akathisia. And if someone has akathisia and they're on, let's say, a lowish dose of any of these three drugs, it could be that there is a 2D6 inhibitor on board with aripiprazole or brexpiprazole. And there are many antidepressants that are CYP2D6 inhibitors, like paroxetine and fluoxetine and bupropion.
Right. And These drugs are commonly used as augmentation for depression. That's an excellent point. Okay. Now, let's talk a little about agitation. Your definition was extremely helpful. People don't, I think, always think in terms of really defining what agitation is. So help us understand a little more about agitation and the way to treat that.
So excessive motor and verbal activity is essentially the definition of agitation. The person who's agitated is clearly uncomfortable as well. And it's addressed by, for example, using an antipsychotic in someone who has schizophrenia or bipolar disorder who is agitated. Benzodiazepines can be used as well. And there's another drug that recently became approved for psychiatric use called dexmedetomidine sublingual film. Mm-hmm. It's indicated for the treatment of agitation associated with either schizophrenia or bipolar disorder. Mm-hmm. And that works differently than a benzodiazepine or an antipsychotic. It works through the adrenergic system in reducing the output of norepinephrine from the locus ceruleus.
I see.
And it was originally developed as an anesthetic agent.
Oh.
And some may know it by its brand name, Precedex.
Yes.
Precedex is not reliably absorbed orally.
Right.
So a sublingual film was developed by the company that markets dexmedetomidine sublingual film for the purpose of the treatment of agitation. It gets absorbed very quickly. The the decrease in agitation occurs very quickly.
Mm-hmm.
Unfortunately, it has to be currently given under medical supervision.
Right.
And thus, we don't see a whole lot use of it. Perhaps if it's approved for at-home use,
yes,
we'll see more of it.
Yeah, that certainly makes sense. Now, you have written quite a bit about agitation and the anti-agitation effects of various antipsychotics. Are there differences in the effectiveness of various antipsychotics for agitation specifically?
So if we look at agitation as an acute manifestation of discomfort, I think pretty much any of the antipsychotics would work, but some can be delivered in ways that lead to faster increase in blood levels, for example. That's why we would give an intramuscular injection of, let's say, olanzapine or ziprasidone. They're available as short-acting for fast-acting IM preparations. You can also give the antipsychotics orally. Mm-hmm. That works too, but there may be a delay.
I see.
But really what's important is engaging the patient in treatment. And if someone says, I'll take something by mouth, well, okay, I'm going to give it by mouth to that person. Unless, of course, there are other circumstances where safety is a concern.
There are also some oral dissolving tablet forms, I believe, of some of these. Would that be an option?
Well, orally disintegrating tablets exist, let's say, for olanzapine, mm-hmm. and at one time marketed for risperidone and aripiprazole.
Right.
They're actually absorbed lower down in the GI tract.
Oh.
They are orally disintegrating tablets, so they can't easily cheek them.
I see.
But the pill essentially has to be swallowed, or the parts of the pill in the saliva need to be swallowed. The exception to this is sublingual acenapine. That's the antipsychotic that gets absorbed in the mucosal tissues of the mouth and does not get absorbed if someone swallows it.
I see.
So the only way to cheek acenapine is to swallow acenapine.
Interesting. Well, that's very interesting. Sublingual acenapine has not been used as much, but maybe there's a role for it in this situation or acutely.
I think so. In a study done in upstate New York in Syracuse, mm-hmm. sublingual acenapine was compared with an equally bad-tasting placebo. So double-blind, randomized, in about 100 people presenting to an emergency department with any diagnosis. Mm-hmm. They provided informed consent, so we exclude patients, of course, there who were not able to do so. But essentially, sublingual acenapine beat placebo quickly and with the same effect size as any other standard treatment.
Okay, well, that's helpful information. Well, what are some common mistakes that a clinician might make when they're trying to parse this out or even treat akathisia or agitation? What kinds of mistakes might they make?
Well, like we talked about, if we give more antipsychotic
Yeah.
to a person with akathisia, it's only going to become worse.
Mhm.
So there is a role here of using a benzodiazepine,
Okay.
which would help with both agitation and acute akathisia. But if there's a persistent sense of inner restlessness after what appears to be an acute episode is over, that lingering feeling of inner restlessness needs to be addressed.
Oh, I see. So akathisia persists, if you will.
Yes, akathisia does persist, and if it's not addressed, it will lead to probably the patient stopping the medication.
Right. And so agitation can be conceptualized perhaps as a little more episodic?
Yeah, so agitation is by definition episodic increases in psychomotor activity,
Okay.
and akathisia can look like someone is agitated,
Right.
but that inner feeling of restlessness is rather persistent. I mean, it's
see.
not there at that same level 24 hours a day,
Right.
but it's not entirely gone.
I see. Now, if we're talking about akathisia, I want to go back to the treatment for a second here. Someone has akathisia, I use an antidote, such as you mentioned, either a beta blocker or mirtazapine, and I hold the dose of the antipsychotic. Will the akathisia eventually get better and fade so I could taper off the other medication?
Well, if you're going to use an antipsychotic and you're not able to change it or decrease the dose, adding a beta blocker or mirtazapine will make it possible to continue that treatment.
Mm-hmm.
If it's contemplated to stop that antipsychotic, you still want to treat the akathisia and start tapering off the offending agent,
Mhm.
and then think of adding or replacing it with something else that is less likely to be associated with akathisia. Now, we have a number of different antipsychotics
Mhm.
that did not demonstrate akathisia in the randomized controlled trials that led to their approval.
Okay.
And that's where the incidence of akathisia in the study was similar to that seen with placebo.
Could you mention what some of those are?
Well, clozapine
Yes.
and quetiapine
Mhm.
were the two antipsychotics where this was first noted.
Mhm.
Lumateperone
Yes.
and iloperidone
Yes.
are two branded antipsychotics where the risk of akathisia is much lessened,
Similar to placebo, I guess.
similar to placebo.
Yeah. Well, that's fascinating. But what about the case where I have the antipsychotic going, I add the antidote, can I taper off the antidote, not the antipsychotic? But
I
say,
see.
Yeah, taper that off. And does akathisia essentially get better over time?
Likely not.
Okay.
So we sometimes observe akathisia, let's say after the first injection of a long-acting preparation of aripiprazole, and then the reports of akathisia become less frequent afterwards. We don't quite know if that's because of the use of an antidote versus it's just not going to be present after some period of time.
Right. So a wise strategy, if possible, would be to lower the dose if I can still control the symptoms, the psychiatric symptoms. But with the ABC drugs, the D2 partial agonists, they all have pretty long half-lives, so it might take some time for that blood level to kind of settle down, and the akathisia then may not go away right away.
Absolutely. If we take the example of the ABC drug that has the longest half-life, cariprazine, it will take about a week for 50% of the circulating moieties to decrease significantly. So we could expect about a week before there's amelioration of the akathisia. This was evident in the clinical trials. And by the way, it was really curious. Those randomized to placebo, it took longer for the akathisia to go away upon drug discontinuation.
I see.
So some of it may be in one's mind.
Yes. Now, is there a withdrawal akathisia ever seen? Has that been reported?
So I would be worried about withdrawal akathisia because that could be maybe point to the existence of what we didn't talk about yet, of tardive akathisia.
That's where I was going.
So tardive akathisia can look just like akathisia,
Yes.
but it occurs for opposite reasons.
Okay.
And it occurs in people who are withdrawn from antipsychotics. It may also appear in someone on antipsychotics, just like tardive dyskinesia, just like the dyskinetic movements that we commonly encounter in TD.
I see.
But tardive akathisia can certainly exist.
Okay.
And there's been quite a bit written about it. Delayed onset akathisia has also been described,
Right.
which has also been categorized by some as a variant of tardive akathisia, because you don't expect akathisia to emerge after some period of months or years. You
Right.
expect it
Right.
pretty much within hours, days, or weeks,
Yes, it's
not months or years.
right.
So if it occurs later on, I think of it as a tardive variant.
That certainly makes sense. And how about treatment of tardive akathisia? Would a VMAT2 inhibitor be reasonable, or the same antidotes I use for acute akathisia?
Well, we don't really know.
Yeah.
It hasn't been assessed in clinical trials. I would address it with whatever is clinically appropriate. If I could address it with a beta blocker, I would. And probably that's what most people would do. If it doesn't get better with a beta blocker or mirtazapine, I would have to think outside the box here, because if we withdraw the antipsychotic or change it, it really won't make a difference.
Right.
By definition,
Right.
it's essentially permanent.
I see. And of course, lowering doses and changing antipsychotics always risks destabilizing a patient.
Absolutely. So whenever you run into tardive dyskinesia or its variants, we have to be very mindful about the risk of altering the foundational treatment that keeps a patient well.
Yeah, certainly makes sense. Well, as we get close to wrapping up here, Les, I'd like to ask you to maybe summarize what are your top pearls here, your top practical takeaways for recognizing and managing akathisia in particular?
Well, I think we need to keep in mind that akathisia is an iatrogenic cause of agitation. And if we can keep it in our differential diagnosis in someone who's agitated, that can go a long way at correctly addressing what we see as agitated behavior. So that's number one. Number two is that benztropine does not treat akathisia. Beta blockers and mirtazapine does. I think those are the two major points. Learn to recognize it and learn to treat it.
Well, I love that. It kind of reminds me of something you and I have talked about quite a bit. Benztropine anticholinergics don't treat tardive dyskinesia very well either, so they're not for all drug-induced movement disorders, despite, unfortunately, how some people have been trained. So I think the idea of thinking of akathisia a little bit separately in terms of the pathophysiology, which we don't fully understand, but also the treatments, is very helpful.
Yeah, I think the less benztropine we use, the better. I say this because benztropine, like all anticholinergics, can impair memory.
Yes.
They also increase the risk of developing tardive dyskinesia.
Yes.
Or if someone already has tardive dyskinesia, it could make it worse.
Yes.
There's no upside to using an anticholinergic, with the sole exception of an acute dystonic reaction. But the treatment of acute dystonic reaction is you give benztropine for a very little period of time,
Right.
and you change the antipsychotic so that you don't give something that causes acute dystonia. You give something else.
Right. Well, of course, Parkinsonism too makes sense, but I think sometimes people think that benztropine in particular is rather benign when, as you said, there's the risk of impairing cognition, there's the risk of urinary retention, constipation.
Yeah, we didn't even talk about those.
No, we did
certainly
not.
in an older person,
Yes.
constipation can be quite serious.
Yes. Well, Les, I want to thank you. This has been a very engaging and clinically relevant discussion. I hope it's been helpful to our audience, and I want to thank you for your time.
Well, thank you, Andy, for having me on this podcast.
You're very welcome. And for those of you listening, for more information about our various products and services and live meetings and podcasts, please go to our website, which is www.neiglobal.com. Thanks so much for listening.
Thanks for joining us for this episode of the NEI podcast, PsychopharmaPearls. Designed for busy clinicians, these episodes bring you focused insights you can put into practice right away to better care for your patients. Please let us know what you'd like to hear more about by leaving a review. And don't miss an episode. Subscribe today. For more trusted education, visit neiglobal.com.